El país con la prevalencia de VIH más alta del mundo se llama Eswatini, está en el sur de África. 3 de cada 10 personas allí tienen VIH, si es que no son más. En estos últimos años se hizo un esfuerzo inmenso por parte del gobierno y organizaciones internacionales como Médicos Sin Fronteras para tratar de combatir la situación que atraviesan quienes residen en Eswatini en relación al peligro que conlleva el VIH.
¿Se puede combatir el SIDA en África? Estamos en Eswatini, en una de las oficinas de Médicos Sin Fronteras. En este lugar, cerca de 1000 personas por mes reciben atención en relación a su salud sexual. Es que este país, en el año 2017, llegó a tener una tasa de infectados altísima. 1 de cada 4 personas estaba infectada con el virus del VIH. Hoy entramos a esta clínica para conocer un poco cómo es el estatus actual de esta enfermedad y cómo se cuidan en general de las enfermedades sexuales acá en África. Vamos a hablar con la encargada del laboratorio. Acá dice Sample Collection, que sería recolección de muestras. Hello. Thank you. It's a pleasure to meet you. So here is where the magic begins.
This is where the sample taken from the patients. So usually the patient will be sitting right over there, and these are all the tools that we use for taking the samples. The normal samples that we take here is usually urine, blood sample, vaginal and anal swabs. That is what we use basically for testing inside the lab. We can go through.
The first time that somebody comes and sits here, most of the times, they have information about what is going on. How do they reach this seat?
The lab. Okay, cool. So what happens is through this window, we usually receive a request form from the clinicians that are the side, and the request form like this will indicate which test they need to do. Already they have spoken with the clinician, they have explained to them what they are suspecting or what they need to test for, and then when they come to the lab, we're also there and explain to them what they are testing for and what kind of samples we'll be taking them. Usually we introduce ourselves, tell them what procedures we'll be doing to them, explain if it will be a little bit painful or not. Usually we just mention that the pain is very minimal, and we'll try to make sure that it is not harmful or anything, and then we will take whatever samples that we need to take. Some of them, most of them, which is the urine and the vaginal swab, they are self-collected. So we show them the bathrooms which are outside the lab where they go and take the samples. However, we do explain to them how to take the samples.
And how many tests you perform? So how many people, for example, each week come here to be tested?
Okay, so we see about 40 patients per week because we work from a Monday to a Saturday. So it's around about 40 to 50 people per week, and usually we test about 3 to 4 tests per person, depending on whatever clinical symptoms they present with or whatever the doctor's discretion is on that particular day.
Which would be the top 5 of the most common diseases that you find here?
The most disease that we actually have, especially with the STIs, is chlamydia. Chlamydia is the most prevalent, I think, in the country, or maybe in the setting where we are. Also, then there is gonorrhea afterwards, and then there is Trichomonas vaginalis. Then we do other more ones like your syphilis, which is about prevalence is about 9% or less. And then we also do some hepatitis, which is way less, maybe 4% or so. Hepatitis B and C, and for C it's quite rare. Very rare.
Are they open to the test, or they are afraid of being tested? Like how do they feel when they come inside here?
Okay, I think most of them, when they come, they are usually afraid of being pricked when we are taking the blood samples. But as I've mentioned before, we do assure them that the pain is very minimal, and we try by all means to make sure that we do not do any harm to them. We are not supposed to be doing any harm
of course
to them anyway.
You are going to help them.
Yes.
Here,
So we make sure that we assure them that the pain is minimal, and if there is an issue, that we cannot handle in the lab, also the doctors come and assist us, especially in taking some of the samples. If we are failing to get a vein or something, the doctors usually come in to assist us in the lab as well.
In sexual relationships here in Africa, is it common to use a condom?
I wouldn't know, but I think so. People are quite aware of condoms and usages and the different condoms, like your female and male condoms, and they do have their preferences. However, I don't think the usage is as much as it's supposed to be. However, we do still reinforce the use of condoms, even though you are on HIV preventative measures, because we still have other STIs other than HIV, like your gonorrhea, chlamydia, which are not prevented by your PrEPs and everything.
Estamos ante la clínica, hay varias oficinas. Primera por acá tenés el psicólogo en caso de ser necesario, por ejemplo, tiene un psicólogo que te asista, y de este lado, she's in the self-testing room, es el lugar donde la gente se puede hacer el autotest del HIV. So how does a self-test for HIV work?
So what we do is we have this self-test that we call the INSTI. So what we do is when a client comes, we explain to them how it works, and then they come into the self-testing booth where they can actually test privately. So we register them on the system. This is what we call the Avero Pocket Clinic. So we just open the app and then we register the client. If the client is not already on the system, we check them first, find client, and then we can find if the client is already on the system, then we just go on their profile and then they can continue testing.
So basically it's something that pinches your finger? That's...
Yes. Okay, they have an option. There's two tests that we use. So we have the OraQuick, which uses the saliva as a sample, and then we have the INSTI, which uses blood as a sample, so they actually choose which ones they want to use. But the INSTI takes 1 minute and the OraQuick takes 20 minutes. So usually this is the one they prefer to use.
So it's a really fast diagnosis.
Yeah, it's a fast diagnosis, this one.
How do you find the work here? How it is with the patients? Is it moving? What are their reactions when they get their diagnosis, when they start doing their treatment?
No, the reaction has been good, and as we are turning a year, the numbers are actually going up now because a lot of people know our clinic and they're actually excited about this because it's longer and they like the privacy, so they can actually do everything here by themselves, so it's fine, they love it.
That must be something very important for a person, for the people that come here, to be able to test themselves and then go along the process with the doctor, because many people are ashamed of the disease, no?
Yeah, most definitely. So whatever it is that happens here, if they need or they want more information, then we also chip in and then we give them counseling. So if they need any more information, then we go into the counseling room where we go ahead with our counseling. Yeah, and give them more information. If they have questions, then we answer their questions.
And how does the counseling work?
What we do is we
Let's go into the counseling room. Let's get some counseling. So I'm supposed to be a patient, for example. I sit down here.
Sit down here, yes.
That's where you usually sit, or
I sit
here?
here.
Okay,
Yeah.
let's do it as if you were doing the counseling. So what are the first questions that you usually ask, or?
Okay, what we do is we introduce ourselves, obviously, and then tell the client that whatever it is that we discuss here is confidential, so they can say anything. And then just to create rapport with the client and make sure that they're comfortable, and then we can ask what it is that brought them in, and then we can move on from there.
And from here, once you've given the counsel, you've talked a little bit, which is the next step of the process?
It depends on what the client came here for, but if they need more counseling, because we have a psychologist just across, so we can refer them to the psychologist if maybe they need psychotherapy or anything more than we can provide this side. And then if they need other services like family planning or they need to see the doctor, then we refer them that side, we take them to the doctor.
So do you usually follow the process of your patients, or you see them once and then they continue with some other doctor?
Yeah, we see them once here and then we take them that side to make sure that they are linked to whatever service that they need, and then that side they continue with them.
Okay, so you are one of the first doctors that they actually meet here.
They start with the nurses and then they come here for HIV testing or counseling if that's what they need, and then we take them there that side.
Estamos con Vanele, él es un colaborador también de Médicos Sin Fronteras. You work for Doctors Without Borders, MSF, for how many years now, Vanele?
I've been here for 6 months.
6 months,
Yeah.
oh, so it's like a short time.
Yes, it's a short time.
What have you seen these 6 months working with MSF?
A lot. I'm the health promoter, so my job is basically community engagement and health promotion to ensure that people know about MSF and they can access the services that we have here. So basically my job is out in the community and inside the facility, because there are people that come here probably for one thing, and then I get to raise awareness on the other services that we have, like psychosocial support, vaccination for hepatitis B, HIV prevention. So you find that once we give them information, now they take their services in packages. So instead of just coming here for probably HIV testing, they then test for hepatitis B and HPV same day, and we're able to aid in that way. And then when I go to the community, same thing. I go to the community, I find out if they know about MSF, I give them a brief history about MSF, and then talk to them about the services we provide here. Probably it's also a mobilization strategy just to ensure that people access our services in this clinic here. Yeah.
And minorities get help also from MSF, or
Yes.
how do you deal that?
Yes, MSF is impartial, so we ensure that all the minority groups we provide information to and provide assurance that when they get here they're going to get the services that they need with sensitivity to their uniqueness in their minority groups. So we work with the young people, we work with students, we work with the LGBTQI community. So part of the health promotion is also working with community-based organizations, mostly led by the minority groups. For an example, like the LGBTQI, they have community-based organizations led by the LGBTQI, and they usually have events where they all come together, sort of like a safe space for them. So we also take advantage of those type of events like the Pride to go there, engage them, talk to them about their needs, and probably even share the information that we have in terms of the services that we provide in the clinic and how they can access them, and the fact that we provide free services. So our job is just to be the face of MSF and try and ensure that they understand that them walking through the system is completely safe, and we are non-judgmental. We just provide medical services to them. Yes.
And for example, if people that belong to the LGBTIQ community, if they don't get help from MSF, can they go seek help somewhere else? Is there some other place they can go to, or are they marginalized?
They are marginalized most of the time because it's not something that is really accepted in Swaziland to be part of the LGBTQI community. Though they are community-based organizations, work with other clinical partners when it comes to providing healthcare services in their different safe spaces. But one thing about MSF is that we always do more. So you find that their clinical partners are only focused on HIV prevention. They don't go as far as hepatitis B testing or vaccination. So that's when MSF comes in to say, yes, you can access your healthcare services with your people or your partners that you have sensitized and went through the capacity building to do this type of job. But then MSF is always there to say, for the hepatitis B, for the HPV that the other clinical partners are doing, please come and access them for those services with us. So it's just basically a relationship. It's a working relationship of saying, we are here for you for those things that other people cannot provide for you.
I started thinking about something that you said about the example of the LGBTEQ community. It is something that is not permitted here in Swaziland, and therefore I think that it must be something taboo for people that belong to the community to be able to be outspoken to their family or to friends about their health issues. For example, if they have some, so the work that MSF does
yes.
is important in that matter.
Very important, because we make sure that the community, whatever minority group it is, they understand that this is a safe space. So we are non-judgmental. We do not care about your past or your race or how unique you can be. We're just saying, if you need any medical services related to the services that we provide here, we are going to make sure that you are priority to us and we provide the best for you. So when we get out there, we do the health talks, we make people aware of probably new diseases that are out there, especially like hepatitis B. A lot of Swazis did not know about hepatitis B. So when we get out there, it's an opportunity for us to engage them, talk about it, then also tell them that we provide vaccination here, we test, so that they know that when they come here, they find a familiar face and we guide them through the whole process. So it is, yeah, they are minority group, they are facing a lot of issues when it comes to the system, but we just try and focus on making sure that they understand that in case they have any medical needs, we provide with out any discrimination.
¿Te está gustando el video? No te olvides de ver todos los otros videos que grabamos en África. Puedes ir abajo ahora, suscribirte al canal. Hay una lista particularmente de África, como también de todos los otros países por los que vamos viajando y haciendo videos. Y bueno, eso, sigamos. Eswatini, el SIDA en África. Estamos con el enfermero, nos va a mostrar un poco la oficina donde atienden a la gente y nos va a contar un poco. Hi, it's a pleasure to meet you. What is your name?
Thank you, sir. The pleasure is mine to meet you. My name is Busiso Ngwanyana. I'm a nurse at Sanziwe Clinic.
And how many years or how many months have you been working here in the clinic?
I've been working for Sanziwe Clinic for about 6 months now.
And what is this in the picture? What can we see here in this picture that you have?
Well, the picture behind me, it's a graph that shows us the procedure that we are normally doing at the Sanziwe for cervical cancer screening. There are two modes. There is the pap smear type of screening, then the VIA, the visual inspection with acetic acid. This is the one. In the pictures above here with the VIA negatives, there are different kinds, of course, because when you put the speculum inside, you might see different features. Here we just have this one with a mucus plug, an Apodean cyst. This one has a polyp. This one has aceto-white lesions, but they are not touching the SCJ, which means our conclusions when we inspect with the visual aesthetic, we conclude that these are all VIA negatives. There are no aceto-whites that are touching the SCJ, so that we can confirm whether it's a positive. Then below here we have the VIA positives. We can see the white aceto-white lesions. They are touching the SCJ. Those are ones. Then these ones we normally say they are cancerous. We normally don't even we don't apply the acetic acid because it's already a lesion, you see. One might even feel the discomfort. It will be painful because it's now it's even bleeding. We just refer the clients to a facility that do biopsy so that they can categorize whether it's a lesion or it's cancerous or not.
And now going back to the more human part of your job. You are one of the first faces people see when they come here. So how is the first interactions that you have with patients most of the time? How is their general mood when they arrive?
Normally they're second person because they start at the vital signs where they are categorized or triaged according to their needs. I normally see patients in this room when they are coming from that side, or maybe they are referred by the doctor to do the procedures or to get their medications, maybe injections.
Is it mostly women or is it?
Yeah, it depends.
50-50
it
or?
Depends, but most of our clients are usually the females. So yes, they come in the room, they get in, I introduce myself and I ask them to sit down. Here trying to create the rapport so that they feel comfortable. Mostly if we're to do the procedure, the first thing I normally do is to introduce introduce and explain the procedure to them. That hey, you are here to do cervical cancer. This is the kind of screening we do, the VIA screening. We explain the procedure to the extent of explaining to them the use of the bed and how they will be expected to behave on the procedure, on the disadvantages. And we also have that is our demo calculator. We also explain to them that whenever we find the client is VIA positive, and it is within the category of our level of treatment, because we have a criteria as to whether our lesions, can we be able to treat them in the facility or we need to refer them into a referral hospital, maybe RFM or Mbabane government hospital. Then if it is within our scope of the clinic, we treat, we show them the thermal, we have the prongs and everything. We explain the procedure again. It's gonna be painful, so we do give them the pain medications, trying to combat the pain, is to minimize the pain during the procedure. Then we also explain the effects after the procedure and also give them the review date as to when to come back so that we can review whether it was a successful treatment and any other further investigation can be done therefore.
Estando en el lugar pudimos hablar de primera mano con quienes tienen algunas de estas enfermedades y nos contaron cómo es un poco la vida allí en Eswatini.
Do you live around the area?
No, I don't live.
Far away?
Yeah, it's a bit far away.
How much far away?
I use a taxi to travel distance.
Like half an hour of taxi or?
30 minutes of a taxi.
Are you married? Are you single?
I'm single. I'm a student and I'm working part-time.
Do you have any children?
No, I don't.
How did you become aware of the work of MSF here?
I saw it on a Facebook platform.
Ah, wow. So you saw it there and that's why you came?
Yeah, I went through the comment sections that I saw people saying it's a good hospital for the sexual transmitted infections, so I went just to check up myself.
And if you don't discuss, for example, if you don't discuss here your health issues, is there some other space or somebody else you can go to talk about this?
I usually tell my mom, and she tells me about these kinds of things.
And she encouraged you to come here?
Yeah, she does encourage me to go to the clinic if ever I have something that doesn't sit well with me, with my body.
And we were discussing a little bit about the use of condoms here in Swaziland in general. Do you think people use them or they don't?
Some do, some don't.
Out of 10 friends, how many use them and how many don't?
I think maybe 4 use them and 6 don't.
So there's a lot of people that don't use condoms.
Yeah, there are a lot of people who don't use condoms.
And why does that happen?
I think it's because the men, they just lie to girls, saying they don't like condoms, they hurt them somewhere, somehow. So they prefer not to use condoms, they feel uncomfortable using condoms, the guys they sleep with. And then eventually the girls will agree to have sex without a condom.
Do you want to get married at some point? Or why not?
Just want to be my own boss, I don't want anyone around me.
Ah, so here, for example, if you are married, your husband is your boss?
Yeah, I think that way. You have to listen to that person.
And you have to do everything that your husband says
yeah,
you're married.
In Swaziland, you should listen to the husband.
And also talking with many people here, they told me that usually men have 3 wives, 4 wives.
Yeah.
That is common?
That is common, and if a guy gets married, eventually go for someone else, leaves the wife at home, go for someone else outside the house.
And as a woman, how do you feel about this?
I don't feel good about it. It's not good. So I think that the men do get bored of having one person at that for a long time. So I don't believe in marriage.
What would you say? There's many women that perhaps don't come to the clinic because they are ashamed or they don't want to discuss this with nobody. What would you tell to women in Africa that don't get assistance regarding their sexual health?
I should say they should not be ashamed of it because it's their health. So it's important to get better. While you are not listening to this, you don't attend to such things, then you get sick and then you might die somehow. So the infections just keep getting worse and worse each day. You don't do checkups for it.
So your advice is get help?
Get help. Immediately you see something wrong, you just have to get help.
Did you find the help you were looking for with MSF?
Yeah, I think I'm getting it because I'm still in the process.
Okay.
Yeah.
Well, I'm so happy that you are doing your process and that you seeked out for somebody to help you.
Yes, I'm so happy too.
Thank you for speaking with us.
Thank you.
It's been a pleasure.
Thank you.
Gracias al trabajo que Médicos Sin Fronteras realiza en Eswatini en estos últimos 20 años, se logró reducir la tasa de mortalidad asociada al SIDA en un 30%. Es un número bastante alto, es mucha gente realmente. Uno de los mayores logros de Médicos Sin Fronteras fue la implementación de los medicamentos antirretrovirales que se entregan de forma gratuita allí y que lo que logran es mejorar mucho la calidad de vida de las personas, incluso hacer que las personas vivan más tiempo. En el año 2007 se hizo un censo para ver cuál era la expectativa de vida de quienes tenían el virus del VIH, quienes habían contraído SIDA, y la expectativa de vida en ese momento estaba en unos 48 años. En el año 2021, último dato estadístico al momento de grabar el video, la expectativa de vida aumentó 11 años, llegó hasta 59 años la expectativa de vida de quienes tienen este problema y atraviesan esta enfermedad en Eswatini. Estamos en la oficina central de Médicos Sin Fronteras en Eswatini. En este lugar ocurre todo lo que es la planeación después de la implementación del plan de esta misión que están llevando a cabo para combatir el VIH. Hoy vamos a hablar con el jefe de esta misión, que es Luis Neira. Vamos a ver si están. Están en casa. Buenas.
Hola Tommy.
¿Cómo estás?
Muy bien, gracias.
Un placer hablar contigo.
Bienvenido, muchas gracias por la visita, por venir a visitarnos y a ver lo que estamos haciendo aquí en Eswatini.
Gracias a vos por recibirnos. Vamos entonces, podemos pasar para tu oficina, ¿te parece?
Por favor, claro.
Recién charlábamos afuera un poquito, Luis, del tema de la diversidad cultural, lo mucho que has aprendido, supongo, en estos últimos 21 años. ¿Qué diferencias o qué similitudes has encontrado con el trabajo en otros países en relación acá a Eswatini?
Sí, como te decía, hay muchas diferencias, ¿no? Eswatini es parte, pues obviamente, del continente africano. Entonces hay muchas similitudes con algunas partes del este de África, digamos con Kenia, Uganda, Tanzania, pero bastantes diferencias con otros países, ¿no? En términos de la actitud de la gente, diferente hacia la ayuda que nosotros proporcionamos. Aquí es uno de los países que más nos acoge, que más nos da la bienvenida, pero en general somos bienvenidos en todas partes. Obviamente es muy diferente a contextos como los del Medio Oriente. Yo he estado en Irak 4 años y medio y 2 años en Irán, abriendo misión por primera vez, y la percepción de la ayuda humanitaria en esos países es diferente, ¿no? Hay un poco más de reservas a aceptar la ayuda, a reconocer que se necesita algunas veces, y definitivamente pues el aspecto religioso y el aspecto cultural son totalmente diferentes.
Uno de los motivos por los cuales decidimos venir a tener esta entrevista, poder tener la posibilidad de charlar con vos y indagar un poco más en lo que está pasando con el VIH, en particular en Eswatini, es por cómo han cambiado los índices de la tasa de contagio acá. En el año 2017 veíamos que 1 de cada 4 personas estaba infectada con el virus, y que hoy se ha llegado al 95. Entonces, ¿cómo se hace para que suceda eso en 5 años?
Bueno, con mucho trabajo, con mucho ímpetu, con muchas ganas de cambiar las cosas, ¿no? Eso fue la idea de MSF cuando llegó a Eswatini, trabajar en este tema, sabiendo la emergencia, porque era una emergencia con esos índices tan elevados de VIH, y gracias al apoyo del Ministerio de Salud, a lo que hablaba anteriormente, a la gran recepción que tuvimos de parte de las autoridades, de parte de la población, fue posible lograr este trabajo, ¿no? Con mucho esfuerzo, llegándole a la gente, ofreciendo servicios de buena calidad, atrayendo a la gente, educando, es un factor importantísimo en VIH, educar y proporcionar información en salud, y cuán importante es la prevención y el manejo de VIH, ¿no? Entonces fue un trabajo de muchos años, de mucho esfuerzo, de mucha colaboración entre diferentes actores y con la población, y para lograr estos resultados tan positivos.
Yo no soy médico, me gustaría tener tu definición. ¿Qué es el VIH y cómo afecta la vida de las personas?
Bueno, el VIH, como son las siglas de virus de inmunodeficiencia humana, es una infección, es un virus que se transmite, ya bueno, todos lo sabemos, a través de intercambio de fluidos corporales en diferentes formas, y que afecta muchísimo la vida humana porque, o sea, el virus como tal afecta el sistema inmunológico de las personas y las hace susceptibles a adquirir otras infecciones que normalmente no deberían ser letales para los humanos, pero que gracias a la disminución de la inmunidad se convierten en letales, ¿no? Y es un virus muy difícil de manejar. Afortunadamente se ha avanzado muchísimo en el tema de las drogas, en el tema de la prevención, que es lo más importante, y en el tema de la educación, ¿no? En el tema de sensibilizar a las personas en cuán importante es cuidarse para no adquirir el virus de insuficiencia humana.
En particular acá en Eswatini, por lo que hemos charlado con algunas personas en la calle, incluso en una de las clínicas que tienen acá de MSF, con algunos de los voluntarios, el sexo o las enfermedades sexuales son un tema bastante tabú dentro de la sociedad en Eswatini, ¿no?
Sí, definitivamente. Yo creo que en muchos contextos es lo mismo, ¿no? Y acá no es la excepción. Y desafortunadamente hay un número grande también de enfermedades de transmisión sexual, ¿no? Y entre ellas, y sabemos que las enfermedades de transmisión sexual facilitan la transmisión del VIH, del virus de inmunodeficiencia humana. Eso fue lo que encontramos, que hay también un gran problema de enfermedades de transmisión sexual que podría afectar los resultados que hemos obtenido con manejo de VIH, y por eso nos enfocamos ahora en el manejo de enfermedades de transmisión sexual, ¿no? De probar nuevas formas de diagnóstico, nuevas formas de manejo de enfermedades de transmisión sexual para tratar de disminuir también esos niveles y de esa forma disminuir también la transmisión de VIH a través de enfermedades de transmisión sexual.
Y en la implementación de esta misión, ¿cuáles sentís vos o cuáles son los principales problemas o problemáticas que has encontrado para la implementación de este programa?
Realmente no han sido muchas. Como te decía, afortunadamente tenemos toda la colaboración del Ministerio de Salud de Eswatini, tenemos la aceptación de las personas de la población que ya nos conoce a MSF por la larga trayectoria que tenemos en Eswatini. Es un poco más la cuestión logística, encontrar el sitio, de implementar una clínica donde no existía, de conseguir los recursos humanos, de traer a los expertos en el manejo de esta temática en el país, pero en general ha sido, si comparamos con otros contextos, con otros países, la implementación de proyectos acá es algo que se facilita un poco de nuevo en comparación con otros sitios.
¿Y actualmente cómo es el trabajo diario que llevan a cabo y cuántas personas hay trabajando acá?
Bueno, el trabajo diario, tenemos una clínica que es de consulta externa que trabaja de 7 de la mañana a 5 o 6 de la tarde, dependiendo. Tenemos horarios, los horarios son flexibles porque nuestro principal objetivo son las personas que trabajan en las fábricas. Matsapa es una ciudad muy industrial que tiene numerosas fábricas, mucho comercio, y las universidades, las principales universidades de Eswatini quedan en Matsapa. Entonces es una población en la que estamos enfocados porque es la población que más se ve afectada por las enfermedades de transmisión sexual. Entonces somos muy flexibles con los horarios, inclusive hemos cambiado de acuerdo con el cambio de estaciones, sabiendo que en invierno oscurece más temprano y que en verano podemos extender hasta más tarde los servicios. Tenemos un grupo de médicos, 3 médicos, 2 médicos nacionales, un médico internacional, que hacen la consulta diariamente, el diagnóstico y el manejo de los pacientes, dependiendo de qué enfermedad se presente, y que tienen el soporte de un gran grupo de enfermeras, de técnicos de laboratorio. Tenemos un equipo de promoción en salud, promoción y educación en salud, que va a la comunidad, que enseña a las personas, que las atrae, que promueve los servicios para que los pacientes vengan a nuestra clínica, y proveemos el tratamiento, ¿no? Todos estos servicios, es muy importante decirlo, en MSF, en todas las misiones, nuestros servicios son absolutamente gratis. La persona no tiene que pagar un solo centavo por el diagnóstico, por la consulta, por el tratamiento, y se hace después un seguimiento, unas visitas posteriores para ver cómo va el manejo, ¿no? Al mismo tiempo, estamos colectando, para nosotros es muy importante demostrar que el sistema que estamos utilizando es efectivo. En enfermedades de transmisión sexual, grosso modo hablando, hay dos aproximaciones, ¿no? Una que es la diagnóstica, que es hacer un examen de laboratorio, diagnosticar exactamente cuál es la enfermedad y hacer el tratamiento directo de esa enfermedad. La otra aproximación es el manejo sindromático, que significa que se trata al paciente de acuerdo a los síntomas, pero sin hacer un diagnóstico exacto. Aquí en Eswatini, en el ministerio, porque hacer el manejo con el laboratorio se complica un poquito por los costos, entonces se hace más fácil hacerlo sindromático, ¿no? Depende de los síntomas, se calcula, puede ser la enfermedad, se da un tratamiento que es más o menos general, pero que puede incluir diferentes antibióticos, y que podría al final, en el largo término, ser más costoso que hacer el tratamiento basado en el diagnóstico. Y lo que estamos tratando de probar es que es más efectivo, más rápido, y en el largo plazo puede ser menos costoso hacer el tratamiento con el diagnóstico. Entonces tenemos también un equipo que colecta datos, que hace el estudio, que vamos a hacer un estudio para tratar de comprobar la efectividad de este manejo que estamos haciendo aquí.
Y por el trabajo que has hecho de este tiempo y el contacto que tienen con los pacientes, ¿cuáles pensás vos que son los factores que hicieron que esta enfermedad se propague tanto, en particular en Eswatini?
Bueno, como te decía, Matsapa es una localidad que tiene una población flotante muy grande, ¿no? Gente que viene de todo el país a trabajar, a estudiar, y que por esas razones, gente joven, gente muy joven, es fácilmente influenciable en el tema, o no influenciable, pero que no tiene mucho cuidado en el momento de tener relaciones sexuales de manera promiscua, digámoslo de esa forma, ¿no? Entonces...
sumo algo ahí, perdón que te interrumpa.
Claro.
Justo hay algo muy interesante ahí, que charlábamos un poco con los pacientes de la clínica y preguntando, decían que sus amigos, por lo general, de cada 10, 8 o 6 no usan preservativo. ¿Eso es un tema cultural? ¿Es un tema de plata? ¿Por qué pasa eso?
Yo creo que es un tema más cultural, ¿no? Es un tema de que te falta, por un lado cultural, por un lado, que no solo pasa aquí en Eswatini, ¿no? En muchas partes es muy, muy difícil lograr que un gran grupo de población utilicen el preservativo por concepciones algunas veces falsas de falta de sensibilidad, digamos las cosas por su nombre, de que no es lo mismo tener una relación sexual con preservativo que sin preservativo, y otras ideas que pueden venir, ¿no? En algunas partes podemos ver que, de acuerdo con la religión, pues usar cualquier tipo de planificación familiar no es permitido. Pero acá específicamente es muy cultural, y yo creo que tiene relación con lo que te digo, ¿no? Con la falta del placer y de lo que causa la actividad sexual. Y es falta de educación, ¿no? Porque la gente no sabe que teniendo sexo desprotegido, en un contexto donde ha existido tanto VIH y donde existe tantas enfermedades de transmisión sexual, el riesgo de contagiarse es muy, muy alto. Pero nosotros trabajamos muy, muy, muy fuerte en eso, en promover la utilización de preservativo, en general, de prevenir la adquisición de enfermedades de transmisión sexual. Es un trabajo que hace mucho énfasis nuestro equipo de promoción en salud, que va a la comunidad, que habla con la gente en la comunidad, pero también que hacemos a nivel de la clínica para informarle a la gente, y proveemos los preservativos también totalmente gratis.
O sea, por un lado es un tema cultural, hay un poco de falta de información, y ¿pensás también que tiene que ver, por ejemplo, el hecho de que acá practiquen la poligamia?
No creo que tenga una relación directa muy, muy grande. Yo creo que es a la inversa, ¿no? La poligamia ayuda a infectar más personas. La poligamia no significa no utilizar preservativo, pero no utilizar preservativo, existiendo la práctica de poligamia en algunas partes, no es tampoco generalizado, puede ocasionar que más personas se infecten precisamente por eso, ¿no?
¿Cómo ves el futuro de Eswatini y de África en relación a las enfermedades de transmisión sexual?
Bueno, es una buena pregunta. Quisiera tener la bola de cristal. Yo creo que se requiere mucho trabajo y trabajo conjunto de no solo la parte médica, es un trabajo a nivel de gobierno, a nivel de educación, a nivel de colegios, universidades, porque depende mucho de la prevención, más que del tratamiento, ¿no? El tratamiento debe ser la última instancia y la idea es no llegar a eso, ¿no? África en general es un contexto, bueno, que conocemos muy patriarcal, muy como decimos en Latinoamérica, del macho, del hombre, que es el que ordena, el que da las normas. Y desde ese punto de vista es un poco difícil por el mismo tema que hablábamos de los preservativos, ¿no? El uso de preservativos o de permitir la planificación de las actividades sexuales en las mujeres. Y lo que decía es la poligamia o no es poli, pero el aspecto de tener varios compañeros o compañeras sexuales es algo muy normal y es algo que culturalmente es difícil de erradicar. Si por lo menos se logra que con educación haya prevención, sería un gran paso, pero es un trabajo difícil y que va a tomar muchos años. No es algo fácil de combatir. Con el trabajo que estamos haciendo acá en Eswatini y que pudiéramos algún día, que lo vamos a hacer, publicar el trabajo, la investigación que vamos a hacer, queremos influenciar eso, ¿no? La práctica de, por un lado, cómo manejar mejor las enfermedades de transmisión sexual, pero cómo evitarlas también, y que eso pueda colaborar para el Ministerio de Salud de Eswatini y otros también fuera en otros países, tomarlo como ejemplo para implementar nuevas políticas en enfermedades de transmisión sexual.
Apenas entramos, vi que tenías un mapa. Quiero que me lo muestres porque por algún motivo lo tenés el mapa.
Es un mapa muy interesante que parece pintado por un niño, pero es el mapa del país, ¿no? Sí. Eswatini es un país muy pequeño con las diferentes regiones, pero que es, no sé, bueno, a mí cuando llegué y lo vi, me pareció muy autóctono, ¿no? Muy de acá, muy hecho acá. Donde nos muestra, por ejemplo, tenemos señalado el sitio donde tuvimos nuestro primer gran proyecto de VIH en Langano, en el sur del país. Y ahora, donde estamos ahora, que es en Manzini, donde está la clínica que vamos a visitar, con la capital donde estamos sentados en este momento, Babane, y que muestra las diferentes regiones y muestra lo pequeño que es el país, pero lo rico que es. Pues el mapa no lo muestra, pero es un país que es muy rico culturalmente, muy rico en recursos naturales, en fauna, en paisajes, y que nos motiva mucho a estar acá, ayudar a la gente para estar aquí, para sacar adelante el problema ahora de enfermedades de transmisión sexual.
¿Hay alguna región, por ejemplo, que tengan más problemas con el tema de las enfermedades de transmisión sexual?
Esta, Manzini.
¿Dónde estamos ahora?
Ahora estamos en
Babane, perdón.
Pero en Manzini es donde tenemos el proyecto, donde tenemos la clínica y es donde
esta es la clínica que visitamos, es acá. En Manzini es la clínica.
Manzini, Marzapa, que queda justo al lado de Manzini.
Okay.
Tenemos la clínica.
Bien, o sea que están en el punto C, en el lugar preciso donde...
Lo buscamos donde estaba y allá fuimos y nos ubicamos.
Muy interesante el mapa. Me gustó gráficamente poder entender un poco más, ¿no?
Bien, se nota mucho mejor, ¿no? Bueno, acá está el problema principal, todo lo que fuiste explicando. Luis, muchísimas gracias. Luis Neira, jefe de misión de Médicos Sin Fronteras.
Muchas gracias por la visita y espero que, bueno, que haya sido una experiencia positiva para ustedes conocer lo que estamos haciendo aquí en Eswatini.
Un gusto y increíble el trabajo que están haciendo.
Muchísimas gracias. Bienvenidos siempre por acá.
Gracias. Las cifras y los testimonios son sin lugar a dudas impactantes. Quienes están allí atraviesan una situación compleja y hay un cambio cultural que está sucediendo ya actualmente allí, pero que todavía queda un largo camino por recorrer. Y es muy importante lo que ha logrado Médicos Sin Fronteras en estos últimos años. El 95, 95, 95. Pero antes de que te lo explique yo, mejor que lo hagan ellos.
I have a question for you, very important. Why did MSF particularly come here to Eswatini?
Yeah, MSF arrived to Eswatini in 2007 after the call from the Prime Minister at that time. It was about declaring the HIV as emergency outbreak in the country. So there was the urgent need to support the HIV services in the country to tackle the increasing trends of the HIV. So following that, the HIV turned to be HIV and TB program. The tuberculosis was also considered to be one of the highest burdens in the country. So our project started in 2007. It was TB HIV and lasted up to 2022. Last year we closed it. So it was a 17 or 18 years of intervention.
If I had to take a guess, when you arrived here, you didn't have all the tools to do your work. Well, which were, other than that, the main issues that you had when coming here and trying to apply the mission?
So as I said, the level of services at that time, it was quite poor. It was the beginning of the HIV services. And when we came here, we saw the urgent need to increase the access to treatment. So the treatment was limited, not available to everybody because of certain medical conditions and because of geographical access also. So the treatment was available in some places and that could be started only with the doctor. So our main primary intention was to make the HIV services available at the lowest level of primary health care. So that was our main target. That took us for 5 years to achieve it. So we visited more than 40 facilities in the southern part of the country called Chiselweni and supported all the facilities on a routine basis with our teams of national and expatriate staff, and with the main intention that people could be tested for HIV there and start the treatment there. And of course this came with a package of challenges that the nurses, you could not find doctors in the small facilities, so we had to go for nurses to start the treatment. And that was something that was difficult to convince the authorities because of the education, because of the certificate that they received. So, but the only way was for the nurses to start the treatment, and it took some years to arrive to that level that nurses could start the treatment. And of course the small clinics do not have the capacity also in terms of laboratory tests, so we went to introduce the idea of small laboratories we call mini labs to implement in all the facilities so that they could do some basic tests to follow the HIV patients' treatment. So all this, it came with some significant challenges in the first 5 years, but it was achieved at the end. The second challenge was to increase the criteria, the medical criteria of patients to start HIV treatment. So at that time, patients could start the treatment only if their CD4 count, it's an indicator, if it was lower than 200. So whoever had more than 200 CD4 count, then he was in the waiting list, did not start the treatment automatically. So our challenge was to push that criteria as high as above 500, and then eventually it became as treatment for all, irrespective of the criteria, the CD4 count or any other barrier. And these two increased the access of HIV patients into treatment of HIV significantly. So that was achieved sometime in 2016. So imagine, after 10 years of intervention, together with the other partners of supporting the HIV in the country, so significant epidemiological achievements have been made. It's recorded and documented. For example, the indicators of the universal indicators of 95% of patients who have HIV, they should know their status, and 95% of those who know their status should start the treatment, and 95% of those who start the treatment should have viral load in their blood. So all these indicators were achieved in a matter of 5-6 years.
Is that common? Because I believe that
Yeah.
it's outstanding. The decrease you've managed to arrange of the illness and how rapidly you were able to implement the 95-95-95.
It was not easy, but I would say it's a significant challenge within a small interval of time. So that's quite good. And now we see even a decline. It's not only stabilized the curve, but also decline in the numbers of patients that in the number of people that acquire the infection on a yearly basis. So just for example, if we go back to 2011, out of 1,000 people, a population of 1,000, you could see 24 new infections every year. So that was the difficult times. Now these 24 infections was reduced down to 6 patients per year. So it reduced fourfold, 4 times, which is quite significant, and it was very much needed for Swaziland. The life expectancy in 2005, it was 42 years old. So somebody born, the life that expected to live was 42 years. And now it's almost above 60 years. And that's because of the HIV. Services were significantly controlled together with the TB. So once the HIV services improved, the TB incidence and the mortality, the death cases because of TB, they reduced significantly. So these two go hand in hand. And these were the significant achievements in terms of access and epidemiological achievements. The other thing that we focused on was the quality of service. So people had access to treatment. They could start the treatment wherever they want, but the quality needed to be improved to keep the patients on treatment, to make the testing as convenient as possible for the people. So the idea of self-testing came into the discussions. So instead of the person coming to be counseled for 15 minutes and then testing and waiting for the result for 15 minutes. So these were turned into self-testing that the patient can test by himself or herself within a relatively shorter period of time. Now we have introduced a method of self-testing with the finger prick that takes less than 5 minutes. So that's a significant improvement. The acceptance of patients increased. So now it's becoming something very easy to do, the testing.
Do you believe that what you have done here in Eswatini can be replied in other countries in Africa?
Definitely. Swaziland was on the front line of absorbing all the international recommendations to implement it because there is the urgency and of course because of the attitude of the decision makers to implement new things in the country for the sake of the patients. There was the viral load testing that was introduced to follow the level of virus in the blood of patients who are on treatment. So this was something very significant for the patients. Once you tell the patient that we don't see any more virus in your blood, it's like telling you are almost cured, but just continue treatment. So this is a significant motivation for the patients to keep them on treatment because they know the result, that there is no virus anymore in my blood. So that's a motivating factor for them.
I know you're a very busy man, but is there something that I didn't ask you that you want the rest of the world to know about what you've been doing, about the very important task that you've achieved here?
I think the openness to listen to the communities, what they want, the decision makers to make decisions related to them, I think is key. Whatever we did was patient-oriented, and addressed for the communities. They participated in decision making. The second is to open doors for innovations. So these were the two main lines for our achievements: openness to innovations and listening to the communities and patients themselves, patient-centeredness.
I don't want to steal any more time. I know you have a lot of things to do.
It's okay.
Thank you so much for taking 5 minutes off.
Thank you.
And congratulations for the work you've done, because what you've done is amazing. It's incredible, and hope you keep on doing the same thing you're doing, because it is giving good results.
Thank you. Thank you very much.
Gracias por acompañarme en este viaje para intentar entender un poco más el trabajo que hacen Médicos Sin Fronteras en Eswatini, particularmente en este caso, sobre las enfermedades de transmisión sexual y en particular sobre el virus del VIH, que tanto trabajo han realizado en estos últimos años y que sus frutos ya se están empezando a ver. Espero que te haya gustado el video y como siempre, nos vemos la próxima.